we should probably get started. We have a lot to talk about today when it comes to emerging topics in women's health, and we really appreciate you all being here. I'm Katie Schubert, and I'm President and CEO of the Society for Women's Health Research, and I'll go through a little bit more about us in just a minute. But just as you're coming into the Zoom room, just a reminder that today's event is being recorded. It will be posted online. We will be sending out the recording and any resources mentioned in our follow-up email to you all. All participants have been muted, cameras are turned off, and that's intentional to highlight our speakers today. You can ask a question in the Zoom Q&A function. We will be doing Q&A at the end, but if something comes to your mind that you want to make sure you put out there, make sure to put it into the Zoom Q&A function. You could use the chat function alternatively, but just know, I think it's probably better to use Q&A. And then if you need any technical assistance, you can write that in the chat. Just know that we do have limited technical assistance while our webinar is running. And then we are offering a live transcription feature. This is the case for all of SWHR webinars. And you can access that feature by clicking on CC Live Transcription at the bottom of your screen. So hopefully that covers everything that we're thinking of. And I think we're good to go ahead and get started. We can go to the next slide, Gabriella. So welcome again. Thank you so much for joining us. Just very briefly before we get to our speakers, and each of our speakers will introduce themselves as they go. But we are the Society for Women's Health Research, and our mission is to promote research on biological sex differences in disease and improve women's health through science, policy, and education. Our vision is to make women's health mainstream. And we look at women's health across the lifespan, and we also look at disparities that might exist among subpopulations of women as well. So really thinking about that continuum of care, the need for research across life stages, disease states, and conditions. Next slide. And so back in 2020, which is when I came on board, we created a strategic map with our board of directors as well as our staff. Our three core pillars, and then we have an organizational strength pillar as well, are science, policy, and education and outreach. And so really thinking about how do we understand health disparities facing women and how biological sex, gender, and hormones affect health. We do that through our science programs. On the policy side, we champion policies that promote women's health, and you'll be hearing more about opportunities related to potential advocacy efforts as well. And then on the education and outreach side, we work to drive the national conversation on women's health and sex differences research. So through our public forums, our social media feeds, our newsletters, et cetera. And then we couldn't do any of those things without our organizational strength to really ensure that our organization is strong and long lasting. We were founded in 1990, and we continue to work to advocate for women's health research, and also to make sure that there are policies in place that are driven by the science and the evidence. Next slide. And so here's our history. As I mentioned, we were founded in 1990. However, this issue of women's health, of women being excluded actively from research goes way back. In 1977, the FDA officially excluded women of childbearing potential from research due to concerns related to both mom and baby. It was encouraged that women were included in clinical trials by the NIH in 1986, but there was work to be done, and SWHR worked with a number of other organizations to get this GAO report that looked at the fact that the NIH was not actually including that many women in their trials. We also worked during that same year to support the establishment of the Office of Research on Women's Health, and we continue to support their efforts through federal funding as well as raising awareness as well. And then hopefully, as you all know, the Journal of Women's Health launched in 1992. So a really long history here in terms of how we're working. Dr. Florence Hazeltine founded SWHR in 1990, and we continue to build on the legacy of making sure that women are included in clinical trials and research, along with other folks who might not traditionally have been included in research. And we still see the effects of that today, particularly when you think about things like the COVID-19 vaccine. Pregnant and lactating populations have not necessarily been included from the beginning, as well as issues surrounding clinical trials diversity. Next slide. And so with that, hopefully very brief background, we will go ahead and turn it over to Caitlin Black, who will introduce herself and go ahead with her presentation.
Thank you, Katie. Hi, everyone. My name is Caitlin Black. I am a Science Programs Fellow at SWHR, and today I will be presenting on assessing priority issues in women's health. Next slide, please. So I'm going to start off with leading causes of death data for the United States, and then I'm going to go into an introduction of SWHR's Women's Health Dashboard, and then we're going to share some of the data that we have on one of our focus areas, Alzheimer's disease. Next slide. So here we're going to start off with this bar graph. And so this graph depicts the leading causes of death for US females across the lifespan for 2018. And now you'll see for the 15 to 49 age group, that's our females of reproductive age group, accidents and suicide were the leading causes of death, followed by ischemic heart disease. For the 50 to 64 age group, ischemic heart disease was the leading cause of death. And for the 65 plus age group, the Medicare eligible group, ischemic heart disease was the leading cause of death, followed by Alzheimer's disease. And so as you'll see, ischemic heart disease was a big one for all age groups, as were accidents, breast cancer, diabetes, and respiratory tract cancers. Next slide, please. And so this table depicts the leading causes of death as seen from the previous graph, but here we've pulled only the diseases which have a higher percentage of all deaths for females compared to males. And so you'll see for each age group, we've included the percent of total deaths for both females and for males. And then next slide. And so on this slide, same table, but we've highlighted in red 25% or greater percent difference in percent of total deaths. So Alzheimer's, influenza, pneumonia, breast cancer, colorectal cancer, respiratory tract cancers, COPD, and stroke. All of these diseases make up 25% or greater percent differences between males and females for that age group. Next slide, please. And here we'll take, this is just a closer look at some of these numbers. So in the red boxes, these are the greatest differences in percent of total deaths between males and females for a given age group. In the first red box at the top, Alzheimer's disease deaths for females age 55 and over account for 2 times the percent of deaths for males age 65 and over. So this is a clear indication that Alzheimer's disease disproportionately is affecting older women compared to older men. In the second red box, breast cancer accounts for a far greater percent of deaths for females across the lifespan, but you'll see it does not only affect females. Breast cancer accounts for a small percentage of deaths among males as well. And then in the third box at the bottom, we see that COPD deaths account for a higher percent of deaths for females in the 15 to 49 and the 50 to 64 age groups. And for that first age grouping, they are small percentages, but as you'll see, that COPD deaths are still 2 times higher for females compared to males for that 15 to 49 age group. Next slide. And so we wanted to create our SWHR Women's Health Dashboard to highlight diseases and conditions which disproportionately affect women. To note, we chose not to focus on accidents, assaults, and self-harm data for this project. So we're just primarily looking at these diseases and conditions. We landed on these focus areas that you'll see at the table by first identifying the leading causes of death among each age group. So you'll see that in the first row. And then we identified diseases which disproportionately affect women compared to males for each age group. That's in that second row. And then we also thought it was important to capture not only mortality, but morbidity as a measure of women's health. So we looked at WHO published data on dailies or disability adjusted life years lost. And that is that last row here. And so as you'll see, depressive disorders emerged as a leading cause of dailies in the 15 to 49 age group. And so we landed on these 5 focus areas: breast cancer, ischemic heart disease, COPD, Alzheimer's disease, and depressive disorders. And we've started our dashboard with 2018 data, and we'll provide updates and progress in the following years. This dashboard also includes various measures that influence health, such as health insurance coverage, access to care, research investment, SABV, or sex as a biological variable, research compliance, and more. And ultimately, we're not entirely surprised by these diseases and conditions which turned up as major players for women's health, but we wanted to show this data clearly and have a tool to bring attention towards these issues and have a system which highlights progress towards addressing these issues over time. Next slide. Of our 5 focus areas, I'll now be introducing just a glimpse of some of the data we've collected for Alzheimer's disease for our initial Women's Health Dashboard launch. Next slide, please. So first and foremost, we performed landscape research and identified disease burden, mortality, and prevalence data availability for each of our focus areas. So for prevalence data, which was primarily published by the Alzheimer's Association, prevalence data was available for sex, race, age, and geography by state. And this wasn't stratified. That stratified data was missing. Disease burden data was available from the WHO for sex alone, age alone, and stratified by sex and age. Mortality data from the CDC had the most complete and stratified data across the board. They provided multiple metrics that were stratified, and as you can see from this table, stratified mortality data was available for each of the categories that we were interested in. And we included this slide because we wanted to highlight that improving women's health through research really begins with complete and accurate data collection, and especially data stratified by sex. Next slide, please. So this slide here is our Alzheimer's disease prevalence for 2018. And you'll see that 16% of females over the age of 5 were living with Alzheimer's disease compared to 11% of males over 65. In the bar graph, the prevalence by race here is actually for men and women. And you'll see that the prevalence for Alzheimer's disease is highest among Black individuals. That's the second blue bar, followed by Hispanic, and then individuals of multiple races or of another race not listed here. Next slide. This map represents Alzheimer's disease mortality among US females, with each state shaded according to its corresponding crude rate for all ages and all races. Notably, the states in the Midwest and Southern US, along with West Coast states, have the highest mortality rates for Alzheimer's disease. Next slide. And this slide is that same map with the addition of states shaded with the highest crude rates of Alzheimer's disease for white, Black, Hispanic, Asian American, and Pacific Islander, and American Indian Alaska Native populations in the US. California had the highest mortality rates due to Alzheimer's for white and Black females, and notably the crude rate was nearly double for white females in California compared to Black females. So you'll see that's 102 compared to 52. And then what we're also seeing here is states with historically larger populations of Hispanic, AAPI, and American Indian Alaska Native populations represented the highest rate of death attributed to Alzheimer's as well. So we see Florida for Hispanic females, Hawaii for AAPI females, and North Carolina for American Indian Alaska females all had the highest rates of death attributed to Alzheimer's disease. And so from this data, one of the goals of our Women's Health Dashboard is to identify notable trends like we see here in the Midwest and the South and racial differences. And ultimately, our hope is that this dashboard can serve as a resource and a centralized place for us at SWHR, but also others in this women's health space to study and look for possible influences as to why we're seeing these trends. Next slide, please. And to try and better understand what is occurring in states with the highest rates of Alzheimer's disease mortality, this table shows the corresponding health insurance coverage percentages for the 5 states with the highest Alzheimer's disease mortality. So our mortality that's females only, but the insurance coverage is actually including men and women. And so again, we're seeing a trend here that the states with the highest Alzheimer's disease mortality are predominantly located in the South. We decided to look at insurance coverage from Kaiser Family Foundation as a potential indicator. Although not stratified by sex, it's important because it's one of those elements of health that, access to care is just so important, and insurance coverage is a good measure of that. So Alabama and Mississippi have a much higher percent of their population that is not insured if you compare that to the US overall. And so this is concerning because we are seeing that these states have the highest rates of Alzheimer's mortality, and they also have extremely high rates of uninsured individuals as well. Next slide, please. And the final bit of data that I'll be presenting today is overall research investment. So in 2018, the NIH funded over 3,000 grants accounting for $1.8 billion in Alzheimer's related research. And that's about 5% of the total NIH budget for that year. We then decided to take a closer look at exactly what kind of Alzheimer's research was being funded by scanning the grant titles for all Alzheimer's related grants. And we looked for titles that include gender, female, maternal, sex, and variations of lactating, pregnant, and woman. We found 29 grants whose titles suggested their research would focus on women and Alzheimer's disease. And so that came out to be 1.4% of that 1.8 billion and 1% of those 3,000 related grants. So again, a little concerning because, as we've seen from the data that I've just presented, Alzheimer's disease disproportionately affects women. Yet the study of sex and gender differences only account for less than 2% of Alzheimer's related research. And so at SWHR, our goal is really to highlight knowledge gaps and unmet needs in diseases that exclusively and disproportionately affect women, like Alzheimer's disease. And to do this, we're creating resources like our Women's Health Dashboard, and my lovely colleagues will be sharing more about some of the work that we're doing. So please look out for the SWHR Women's Health Dashboard. It'll be up on our website in the coming months. And thank you very much for your attention.
Well, hello, my name is Irene Aninye. I'm the Chief Science Officer for SWHR, and I'm going to talk a bit about the approach that we have taken at SWHR to address these knowledge gaps and to help provide our insight as to how to prioritize research efforts. There are many valid approaches to advance women's health research and care. And so I'm going to give just a bit of insight as to the models that we've used here at SWHR. Next slide. Unfortunately, the healthcare system has various kinks and stressors that distort what should be a lovely and perfect equilateral triangle that reaches all corners or people equally in healthcare and in women. But women's health has historically been pressed by health disparities, inequitable access to care, and lack of sufficient resources, among other factors. And so if we don't plan for and address these stressors, women's healthcare and research will never advance to the levels of understanding and quality care that are required to close the gaps. Next. The stressors that I've identified here affect women's health and the healthcare system as a whole, but have particular interactions with certain players. So for example, patients, these are the individuals who are in need of receiving care. Women are impacted by health disparities due to biology, but this audience already knows the importance of SABV in biomedical research. But there are also disparities and inequities that are due to social, cultural, and environmental factors that are unique to women. Providers are those who are charged to develop, study, and dispense care. They are at a unique space because they serve as a pivotal gatekeeper for care. They are responsible for identifying and communicating options and opportunities with their women patients. So biases, whether they're positive or negative, can come into play. But also providers can be limited by insufficient and inadequate knowledge, training, or resources. And that's where understanding the gaps in research and limitations in our healthcare system that are a bit beyond their control, but we look to be able to make advances there. And so there are added factors, of course, of geography and workforce development that present challenges to resource availability. Our third group are policymakers, and these are the entities or individuals that get to validate the priorities when it comes to policies and interventions that are going to ensure both equality and equity in healthcare, especially when it comes to addressing women's health. Now, a bit of a disclaimer is that, this diagram indicates arrows pushing only on one group, but we know that patients, providers, and policymakers are not discrete categories. They all interact with each other, and the individuals often wear multiple hats between groups, depending on the situation. And so at SWHR, the changes that we push to address are grounded in our ability to convene interdisciplinary networks that engage these three perspectives. Next slide. And so providers, these include researchers who provide knowledge, clinicians who provide care, and pharma who engage often in both. Their perspective is really important to identify and address knowledge gaps, whether it's in research, education, clinical training, but they also tell us what implementation looks like, comparing it to the patient experience. And so these often are the experts that decision makers want to know have vetted and co-signed on the evidence that are being used to back up various requests for increasing research investment, for changing policy, for making guidelines. And so a lot of the perspective that comes from the provider group comes during conversations amongst a diverse group of providers, and that's really important. The audience and the experiences of this provider group shapes their narrative, whether it's rural or urban setting, whether they have R1 resources, what the socioeconomic status of their patient population is, what their clinical and research specialty might be. Do they work with an LGBTQ population? Do they have a concentration, or do they have a diverse set of cases that they see? Acquiring their expertise through conferences like this, closed meetings, publications, systematic reviews, advisory committees. Scientists love to talk science to other scientists. But we have to remember that even in scientific meetings and academic spaces like this one, they draw in audiences across sectors. And so our content has to be presented in a way that it can reach a diverse set of ears. Next slide. And so allies are a must. Policymakers are composed of either decision influencers, which can be lobbyists, advocacy groups, professional societies, or decision makers, whether at the local, state, or federal level. And so a lot of times we find as scientists, we want to try to change their minds or convince them of our cause in women's health, but sometimes shifting our focus a bit to realize that we can learn from the policy folks as well. You know, policy stakeholders provide insight to barriers to implement policy implementation, whether they're real or perceived barriers. They also have a focus on checks and balances and putting in place accountability measures. So what do the decision makers value? That's something we have to take into consideration. But as we all know, a lot of times policy stakeholders often hold the purse strings. And so engaging in the policy space at any level requires value alignment. We have to demonstrate and communicate a need that they can appreciate with clear and concise asks. Numbers and names often matter. So a better response is gained when a recognized or trusted source, whether it's a person or an organization, is presenting that information. Credibility and track record is vitally important. And then also really consider that there are strengths in numbers. On the policy realm, there is a cost benefit analysis. How does the research that we're presenting relate to their constituency? And so in the next slide, their constituency is just that. They are patients in the patient grouping. Next slide. So our patient grouping includes not only individual patients, but caregivers, family and support systems, and patient advocates. This perspective really helps us to understand the experience, the bumps and the roadblocks that an individual gets along the patient journey. And so patient advocate organizations, they also can help mobilize community for events, but partnering with them is important, not just using them, but really partnering can amplify the voice of the research or the cause that we have, be it in Alzheimer's disease, menopause, osteoporosis, or what have you. And so SWHR, we include patients and patient advocates in our working groups, not as guests, but as participants, because it's a constant reminder to all of our work, the impact of our current healthcare system's ways on the women that it is affecting. And so we engage them as well as presenters at public forums and congressional briefings. Next slide. So as we've mentioned before, and just echoing at SWHR, our dialogue surrounds women's health, the recognition of sex as a biological variable that influences disease, research and drug development, the inclusion of women and minorities in clinical research, and strategies to improve healthcare and quality of life for all populations of women. And so in order to remain a neutral space, we found it's important to include researchers and clinicians and federal agencies and patients and patient advocates, and yes, at times even industry, whether it's pharma or biotech, to ensure that those who influence health planning and care are all at the table, sharing their important perspectives that can allow better solutions to be developed. And so in your respective women's healthcare space or research space or jurisdiction, you have to be able to identify who will be an effective neutral convener to champion your women's health focus. They have to have a positive reputation, enough influence to draw key collaborators in, and a history of demonstrative results. And so we try to tackle our work from research gaps. We look at clinical care, education needs for patients, providers, public and policy. We look at also regulatory and legislative policy, and then advocacy needs. Next slide. And so continuing with the example of Alzheimer's disease, I want to walk through how SWHR pushed against the deformity in women's healthcare for Alzheimer's. We have a history with it, but this timeline particularly will start in 2011 when SWHR held an interdisciplinary roundtable and meetings and various meetings convening the diverse perspectives that I talked about to review the roles of sex and gender in Alzheimer's disease. We still hold meetings like this now. In fact, just yesterday, we held one on psoriatic arthritis and the impact of this immune-mediated inflammatory disease on women's health. And so depending on the priority areas that our expert working group recommends to address, we look at, as far as key gaps in the field, we determine where and how to take action. There's both short and long term. And so from this meeting in 2011 and a series of meetings then, we published a report in the Journal of Women's Health, which was a bit of a call to action that identified sex-based research questions for the community to chew on. And so over the next couple of years, we promoted opportunities for researchers to engage in conversations and establish collaborations to address these pressing areas of need. Next slide. And so as we progressed over the next couple of years in 2015, we held a follow-up roundtable to review the advances over the previous few years, but we also added the impact of Alzheimer's disease on caregiving to the scope of our work. And so we know now and then as well that caregiving disproportionately impacts women in addition to the disease itself. And so then we set up a formal network that would now help us to champion this women's health topic through additional efforts across science, policy, and educational outreach. And so over the next 3 or 4 years, there were additional publications to reach the academic and clinical community. There was media attention that was used to reach the public, and commentaries and statements that we used to build awareness and support in the policy space. And so it was really important that our approach was dynamic and multi-pronged, evolving as the needs of the landscape also changed. Next slide. And so by the time we get to 2021, over those next couple years, we continue to build and participate in coalitions and partnerships along the way. So seeking sponsorship was important. Who else is interested in Alzheimer's disease and women's health? But also advancing research and academic investment. What questions needed answers? What were the pressing answers that were needed, short-term and long-term? And then also clinical support and feedback were key. How do these proposed solutions actually play out in real life? Next slide. And so our work doesn't stop. As we mentioned, we have launched this year a women's health equity initiative to highlight disparities in Alzheimer's disease, among other conditions. And then the dashboard that Caitlin just talked about, that's going to help us track progress and provide a central resource for others to help in their efforts to address disparities, access issues, and resource availability concerning Alzheimer's disease and women's healthcare. You know, this is not all that we've done, but it's just a snapshot to illustrate the various angles that we took to one particular women's health topic and to encourage you all that it takes time and investment in the long-term strategy to affect change. Next slide. So we can make the system look nice, right, and have our perfect triangle back, but it won't achieve equality if it's not inclusive for all women. We have to plan for diversity at multiple levels. Even a focus on women's health has so many diverse subpopulations based on genetic ancestry, race and ethnicity, geography, socioeconomic status, sexual orientation. One size does not fit all. And each issue doesn't affect everyone the same. And so it's important to understand the stories. So when we're looking at stats in our research data, that we pair them with a story. The data is important, we're scientists, but the people remember stories better than numbers. And so it's so important to find ways to marry the two as much as possible, even in presenting your research, whether it's not a patient story, but it's understanding how is your work applicable to the audience that you're speaking with. And so we found that providers also need and want to learn how to do their work better when it's meaningful. So for example, our fertility program identified a significant knowledge gap concerning infertility testing and treatment options among general OBGYNs and patients. And so not everyone has access to a reproductive endocrinologist and infertility specialist. So we developed 2 resource guides, one for women and one for providers, that were companion pieces to help each group better interact with each other and promote women's health care and quality of care for women when it comes to fertility planning. And so as changes roll out with new research advancements, clinical guidelines, et cetera, we have to help the gatekeepers adopt the technology, the training, the accountability, and we also have to help the consumers, which are women, to utilize these advances. So telehealth is great, but if you have access to the internet and stable connection and are tech savvy, it's wonderful. And definitely the pandemic has helped us with that. But if you don't have those features in certain areas or pockets or rural areas where telehealth is either not supported or your infrastructure, technology infrastructure is not as advanced, that can be a challenge. And so one of the things, for example, that came out during our Women's Eye Health program, the group highlighted a particular group in the field that use a centralized hub in the community in a soup kitchen. And they use the hub of a soup kitchen to set up a telehealth station with retinal imaging technology. And so this was a very innovative way to bring this service to a vulnerable population that had limited access otherwise. And then it was also something that was sustainable during COVID. So providers, patients, and policymakers are all gatekeepers in their own ways. And each respective group has their own set of needs, their unique contributions, and much to learn from the others. Every perspective is necessary and valuable. And so we have to provide better and healthier spaces for patients, providers, and policymakers to interact and to develop these holistic solutions that are also sustainable to improve health outcomes for women. And so with that, thank you for allowing me to share that piece, and I will turn it over to Lindsay for our next segment about policymakers.
Thank you, Irene, and good afternoon, everyone. My name is Lindsay Horan, and I am the Chief Advocacy Officer at SWHR. Today, I'll be covering some advocacy fundamentals, including what it is and tools that you can use to engage, and also just sharing why advocacy is important for shaping public policy. Next slide. So first, Advocacy 101, it's important as we enter into this conversation to remember that American citizens have a constitutionally protected right through the First Amendment to lobby their government. You have the right to ask the government to respond to your concerns or issues, and you can encourage or discourage them to take action on any given issue. Next slide. There are important distinctions, however, between advocacy and lobbying. Due to federal tax regulations on lobbying, there is a legal difference between the two. So advocacy is an all-encompassing umbrella term related to championing an issue or a cause. I tend to think of advocacy as education on a given issue, and lobbying is the attempt to influence specific legislation. So this may include asking your member of Congress to vote yes or no on a certain bill, or asking lawmakers to provide more funding on a given federal research or public health agency. And then some organizations break it down even farther and then make a distinction between the two different types of lobbying. One of those is advocating directly to a federal employee about adopting or rejecting a bill. And the second type, which is grassroots lobbying, is urging the public to contact their lawmakers on a certain bill. So in summary, while all lobbying is advocacy, not all advocacy is lobbying. And since I know some members in this session are in academia, I will also note that over the years, I've spoken with many university employees who have expressed concern about advocating due to their institution's rules regarding lobbying. So as you think about that, it's important to note that colleges and universities do not want to infringe on their faculty and staff members' First Amendment rights. There are also these principles called the Principles of Academic Freedom that state that colleges and universities recognize that professors, as members of a learned profession, have the right to speak or write as citizens free of institutional censorship. At the same time, universities are also subject to federal lobbying laws, which provide thresholds and definitions of lobbying activities and contracts. And because of these requirements, when it comes to faculty and staff advocating, there are typically two things that universities' government affairs staff look for. And those are if the individual claims to be speaking on behalf of the university, or if they are using university time or resources to engage in a partisan activity. Ultimately, you should consider your university's government relations team as a resource and consult your university's policy manual to determine what's permissible. But assume your university's government relations team wants to know about any of your personal advocacy or lobbying efforts, while at the same time knowing that your First Amendment rights are still your First Amendment rights. Next slide. So whether you are a researcher or subject matter expert, an individual working in healthcare, or a patient advocate, you sit in a pivotal position for shaping public policy. Because while evidence is important, it is not sufficient to affect change at the federal level. Not every staff member or policymaker is going to be reading the latest peer-reviewed journal highlighting new areas of promise in research or results from a demonstration project. You can be the one to connect those dots. Not only could you be making policymakers aware that this information exists, but you also have the ability to break down the research study and explain how its findings have implications for public health and healthcare. You can also best demonstrate why investment in research or changing a given policy is necessary or important. There are real budgetary considerations under which policymakers are operating, particularly right now after years of providing emergency funding to respond to the COVID-19 pandemic. Money is tight, and there are a lot of people making the case that their issue or cause should be the one getting that piece of the pie. Congress makes funding decisions line by line, and they cannot do it alone. There is a saying that we use in Washington: if you're not at the table, you're on the menu. And what that essentially means is if policymakers don't understand how certain research or a certain public health entity is making a difference in the lives of the American people, and particularly for their constituents, it's easier for them to cut funding and feel like there won't be any negative ramifications for doing so. So that's why you often hear messages about the importance of making your voice heard and getting loud on certain issues. Policymakers need to know about what issues matter most to the people that are responsible for electing them into office. Next slide, please. So you have the potential to create change. How do you go about it? These are some of the tools that may be available to you to engage on the policy issues that matter most to you. So to start, there's direct communication with policymakers. Some of these are really simple and some require a little more lift and a little bit more effort. So at the lighter end of the spectrum is engaging with your members of Congress through phone calls, emails, action alerts. And I should say what I mean by action alerts are those campaigns that you'll see from organizations occasionally saying, text this number to send a message to your lawmaker about this bill. The messages are often already drafted, but they are usually customizable just to make it as easy for the advocate to take action as possible. There's also the option to engage on social media by sending a tweet or sharing a Facebook post. And I know that social media isn't always what springs to mind as an advocacy tool, but it can be quite effective. There was a 2015 report from the Congressional Management Foundation that surveyed Hill staff, and that report said that more than 3/4 of congressional staff either agreed or strongly agreed that social media has enabled them to have more meaningful interactions with their constituents. In that same survey, about 1/2 of those surveyed said it takes between 10 and 30 similar comments on social media for their offices to pay attention. 1/3 said it takes fewer than 10 similar comments for them to pay attention. So in the grand scheme of things, 10 tweets to get a member of Congress to pay attention to a certain issue is not a lot. And then one note that's worth considering if you choose to go the social media route is staff indicated that they did have a hard time identifying constituents. So if you do tweet at your member of Congress, it's good to include that you are a constituent within the body of that tweet. The next level of advocacy tools requires more effort from advocates, but this includes potentially arranging meetings with your elected officials if you come to Washington, D.C., or if they're in the district. It could include attending one of their town halls, coordinating site visits for members to come visit your institution or a lab. If you're at a university, you would want to coordinate this through your university's government relations team. But those can be effective for members to see what you're working on, and really letting them put a face to the research that's being done. And then for each of those tools, they may be done individually, or you may opt to engage through a coalition or a professional association in which you're involved. Coalitions can be a great way to keep track of issues you most want to follow and staying up to date on things like Hill Days, where these professional associations bring in their members to advocate on a specific issue or on a certain bill. So those are really great ways for kind of keeping a pulse on ways you can engage throughout the year. And finally, a tool that may be less thought about as an advocacy tool, but could be particularly good for subject matter experts, is engaging on the regulatory side. So this type of advocacy involves commenting on a regulation in an attempt to influence the outcome of the regulatory process. Federal departments use this process when developing rules or when standardizing processes, and it could include things like agency strategic planning initiatives, licensing and accreditation requirements, scoring criteria for health professional shortage areas, or even things like public access to peer-reviewed scholarly publications that result from federally funded scientific research. So there's a really broad swath of things that might be included on the regulatory side. You can monitor and respond to these requests for information and comment as you choose. They are announced daily in the US Federal Register, and you're able to sign up and get those digests sent directly to your inbox if that sounds like something that might be of interest. Next slide. The other tools at your disposal may not be direct advocacy tools per se, but could be used to get information into the hands of policymakers. So this could be anything from writing an op-ed in response to something that was shared in your local newspaper, or it could just involve you sending a quick note to the staffer with whom you formed a relationship with some key takeaways they might find of interest from a recent scientific conference or from a journal article that you've read lately that you know is of interest to their office specifically. So be sure to keep those tools in mind as well. Next slide. So regardless of the method by which you choose to advocate, there are a few things that I always think are helpful to keep in mind. To the extent possible, it's helpful to tie your advocacy into the legislative process or use current events or things in the news to really make your case and make sure it's relevant to policymakers. So as one example, the federal budget process provides an important opportunity to inform lawmakers' funding decisions, but there are entry points for researchers and advocates to educate elected officials. Since the federal appropriations process does not ever really fall on time anymore, a general rule of thumb is between late spring and early summer can be a key time to engage. And this is kind of after lawmakers have held congressional hearings with agency officials on the next fiscal year's budget, and while they're actively in the process of drafting and approving legislation in their respective chambers. Both the message and the messenger are key. So for the message, it's helpful to remember who you're speaking to and what issues matter most to them. Do they have priorities related to your work that you could use to lay the foundation for your conversation? Is there a health issue that's having a disproportionate impact on their county or city or state? All of those can be useful to keep in mind. Additionally, it's helpful to consider from whom that message might be best received. Irene mentioned this in her comments as well. Credibility and track records matter. So does the member have a relationship with someone or a connection that would allow the message to resonate more than it might from someone else? And then there's also relationship building, which that speaks to. For advocates, it's really ideal to begin to develop relationships with staffers before you have an ask to make. And that relationship building can really work in two ways. On one hand, you'll have a receptive audience when you do decide to champion a cause. But on the other hand, through your relationship, you can position yourself as a resource and share information about your work. So if something comes up in that office, whether it's a policy or a piece of legislation that's being introduced, that staffer will know to reach out to you because of your expertise. So that relationship building piece is really critical. And then finally, it's helpful to remember that advocacy is both proactive and reactive. You can respond to legislation that's introduced, but you can also start sharing information and resources that could have an impact down the line. Next slide, please. So putting it all together, these are some of the ways in which SWHR has engaged in advocacy on behalf of Alzheimer's disease, which we've kind of tried to create as a theme throughout our presentations today. So this is a snapshot of what we've done, but as you'll see, we've used a range of advocacy tools, and I'll also note that this doesn't capture our meetings that we've had on the Hill or engagement that we've had on social media. And I also won't go into all of this in detail. It's available on our website, but a few things that I will call out that SWHR has done kind of over the past year. So first, we've engaged with the Leaders Engaged on Alzheimer's Disease Coalition to champion policies related to Alzheimer's disease. And again, it's helpful to tap into coalitions as people who are working in this space day in and day out. They can help us keep a pulse on policies and regulations coming out that may affect the Alzheimer's disease population or their caregivers. And through the LEAD Coalition, we have encouraged Congress to provide funding increases for Alzheimer's disease-focused research programs and initiatives in the fiscal year 2023 appropriations process, And we also recently sent a letter to FDA's advisory committee on the unmet need for individuals with Alzheimer's disease-related psychosis. We'll also continue to engage with Congress by sending letters, sharing resources, and next month we'll be hosting a congressional briefing on Alzheimer's disease's disproportionate impact on women, both as patients and caregivers. So ultimately, when it comes to public health advocacy, you will see that it's a multifaceted approach. There are so many different entry points to engage and to begin to shape policy that could better serve women and their families and improve outcomes. And for systems level change, we really have to take a systems level approach. And all of this does make a difference. Together, the advocacy of Alzheimer's disease stakeholders has led to the passage of the Building Our Largest Dementia Infrastructure for Alzheimer's Act, which was aimed at enhancing and improving the nation's public health response to the Alzheimer's disease crisis. And it increased federal research funding for Alzheimer's disease, including a $289 million increase in 2022, which provided a grand total of $3.5 billion across the federal government. Next slide. So for those that are attending this Zoom today, there are so many pieces of legislation and opportunities floating around to impact women's health. On the Hill, here is just a small snapshot of some of the things that you may choose to engage in or places where you may decide to weigh in. The first is the federal appropriations process, which I've mentioned a few times today, but you can reach out to members of Congress about lessons you've learned from a federal research grant that you've received, or why dedicated research funding is necessary, or where there may be clinical care and policy gaps that could affect outcomes for patients. There are also several pieces of legislation about issues that affect women exclusively. Two of those are the Endometriosis Care Act and the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act, both of which would provide targeted research funding and have an element for a public awareness campaign. There are also several bills packaged into this Momnibus bill, which directs multi-agency efforts to improve maternal health, particularly among racial and ethnic minority groups. And then there are also several pieces of issue-specific legislation if there is something that you engage in regularly. So two examples here are the Increasing Access to Osteoporosis Testing for Medicare Beneficiaries Act. And this bill would restore reimbursement levels for Medicare Part B for bone mass measurement that use DEXA services to 70% of their 2006 levels. And since we've been talking about Alzheimer's, I also pulled a bill here, and it's the Alzheimer's Caregiver Support Act. And that would authorize grants to expand training and support services for families and caregivers of individuals living with Alzheimer's disease or related dementia. And then finally, I just included shaping evidence-based policy, but really just tying back into the earlier comments of paying attention to what's being introduced, paying attention to what's in the news, and particularly if you work in that area or you're aware of research that could be integral for policymakers as they build this, as they craft this legislation. We really want to make sure that pieces of legislation that are introduced in the healthcare policy space are grounded in that evidence, so that we can make sure that we're doing what we can to improve outcomes for women. So with that, next slide. I will just share that if you would like to lend your expertise to SWHR's advocacy work, I invite you to email me. We are always looking for subject matter experts to engage. SWHR engages throughout the year on a wide range of policy topics on a number of areas that either differently, exclusively, or disproportionately affect women. And so we would love to have you in our network and call upon you as needed. So thank you so much for your time. And I will now turn it back over to Katie.
Thanks, Lindsay. So I think there's a number of issues here as we're thinking about how the work, how the science drives the policy, which then drives a lot of the sort of national conversation. And one of the things that is really sort of centered within this work is how to engage and amplify patient voices and their participation across the spectrum when we think about from the research to the policy to the advocacy work. Next slide. So one of the things that we've been working to do, and as everyone has said, throughout this webinar, is really thinking about how do we center the patient voice. What we mean here is how do you take the person who is being affected by this, and I would even say this does translate into sort of what we talk about when we talk about storytelling and sharing. It's not just the voice of the patient. When it comes to women, we are patients, of course. We're also caregivers. We're also the chief medical officer of the family. And so how to engage this particular voice when it comes to improving your health and the health of others is really critical. Really thinking about the value of and the experiences of people, and how do you solve a problem or a research question from that perspective is really important. And it is something that has been growing in terms of how we use that patient voice, but also how to better engage them. Data will give you information. The stories make it real, and you really need both to be able to answer those questions. One of the phrases that I have on a Post-it note at my desk is information is power against stigma. And it is no clearer when we think about stigma than it is in women's health, because across the board, no matter what issue we're talking about, whether it's a life stage or a condition or a disease or something that is specific to women or something that might differently or disproportionately impact women, is this idea that stigma exists. Talking about women's health is taboo. It is really difficult sometimes for people to be heard. And it also engages in terms of the issue of how do you make sure that that story is being told in a way that it is being listened to. So for us at SWHR, we amplify the patient voice in a number of ways by first incorporating them into the roundtable meetings. And as Irene said, we are not just inviting people to come in and tell their stories and leave. We want them engaged in the entire process of a scientific program from beginning to end. We want to make sure that their voices are heard and also that their perspective is valued just as any other experts' thoughts and opinions would be valued as well. We share these patient stories in our webinars and in our briefings. We always have that perspective throughout as we're talking about a particular topic. We feature their stories through our blog posts, but also videos. We have a patient story bank we call it a women's health journey. And just as an aside, as we think about being a patient in women's health, I think it can get a little bit tricky in terms of how we think about it, because something like menopause or pregnancy, those are not diseases, yet you are still sort of taking a perspective of sharing your health journey versus necessarily being considered to have a specific disease that you are advocating for more research for or access to care, et cetera. And then we disseminate these things widely. So that's where the education and the outreach really comes in. So through newsletters, driving that conversation through social media, hosting events like this and this webinar, and really thinking about how do we get others to think about women's health and research the way that we're thinking about it as well. Next slide. And so one of the ways that we have done this as an example in Alzheimer's disease is really thinking about the perspective of women as patients and caregivers, and how do we collaborate with condition-specific groups, right? We're very broad when we talk about women's health, but everybody has their area of specific expertise. We want to be able to amplify that, and I think that's where our strength is, but it also is in the strength of all of those who are out there doing the research, who are caring for patients, and who are patients and caregivers themselves. We recently launched the Women's Health Equity Initiative just a couple of months ago, and there is a hub on our website which shares data and pairs it with stories. And so I want to share our caregiver video here now, and I'll ask Gabriella to go ahead and get that started.
name is Carmen Morales, and I am a Latina. I was taking care of my mother at my house for a number of years. My mother was actually diagnosed with Lewy bodies dementia in 2018, but she had been having symptoms since 2011. There was just some problems in getting the right diagnosis. And she had all these really great stories. And yeah, I heard them a million times, but I enjoyed them. So I started noticing first that the stories were changing. At the beginning, it was little changes, but then later on, it was the bigger changes, like the timeline or the names of the family that have been involved or the people that have been involved. When she started realizing that she had to really think about what she was telling me, she started becoming very agitated. She would become upset. A couple of times she broke in tears, which it was very sad to see. First problem we had was that the test was not in Spanish. I had to interpret to her what was being said. And I could see that the doctor couldn't really quite judge how it was. I could tell them, I'm not a doctor, but I could tell them that she wasn't passing the test. She had a stroke that year, and they sent us to a neurologist. That was finally the person that could say, beyond a shadow of a doubt, this is dementia. So it was a struggle. It took us all those years of visiting doctors, visiting neurologists, and we couldn't get her diagnosed. As a caregiver, I was frustrating because I tried to explain to them what was happening. And some of these doctors did not want to listen to what I was saying. So it was frustrating. Meanwhile, I had to keep her, make sure that she doesn't get agitated and upset, because I admit it, when she was upset, she started crying. It broke my heart. In terms of culture and diversity, the hospitals are not very culturally friendly. The one thing I'll say is they're getting more and more staff that's bilingual. And my mom always responded well when somebody was speaking Spanish other than me. And I noticed when she had, in this last visit, she had a Spanish-speaking doctor in charge in the hospital. And even as far gone as she was with her dementia, she was responding really well to him. Government agencies, the health system needs to acknowledge that we're not all the same, that they need to take care of everybody the way it appeals to them. And definitely to caregivers, don't give up. And I hope that they have faith, because faith helped me a lot to go through this. If I could help anybody, I'm glad I could help. I always told myself, I wish there was somebody who could talk to me like this. And eventually I found the people, but if I could help anybody, I'm really happy to be able to do it.
Thank you so much, Gabriella. So I think, quite honestly, stories like Carmen's, and we're so grateful that she's willing to share her journey and her experience with her mother, which in a number of ways illustrates some of the challenges that we're seeing, really help us also think about what is of value to patients so that we can better craft a research question, we can better engage with the population to get them what they need. It's so powerful as well when you share these stories and you pair it with the data and information that you're finding. So I think key takeaways for me in terms of participation and inclusion throughout the process, when you think about healthcare generally and research generally, but in particular in women's health, is really including this perspective at every stage. Meet people where they are and find out what is important to them. It is going to be different for each person, what they value most and what they would most like help with, or questions that they might want answers. Building trust is really critical as well. You need to make sure, again, that people are being heard, feel that they are being heard and really participating in the conversation. And then broadly, I would say for women's health, something that we have been fighting for is to ensure that the trial population reflects the treatment population, whether that is sex and gender breakdown, race or ethnicity, geographic location, really thinking about those issues up front as we're considering various research questions or conditions or disease states, and trying to gather information and data to better address health disparities in particular. These are things that we need to make sure we keep in mind from the beginning. And so with that, I will go ahead and ask our panelists to hop back on camera. We have some questions coming in. I'll remind folks, use the Q&A. We will do our best to address questions sort of thematically as we're able. And I might first just ask if there was anything sort of in particular that came to mind as we're sort of having this conversation that you wanted to make sure that you added before I ask one of these questions that I think is really important here. Okay. All right. So question here. And I'm going to ask it and I'm going to answer it, but I'm also going to ask for others' input on this as well, because it's something that I think is really important and is emerging in real time. So the question is about how we will track the disproportionate impact of long COVID. And there's some other very specific conditions, chronic fatigue being one, but these are things that we know disproportionately affect women. We know that they're a leading cause of disability and loss of productivity. And it is certainly emerging given the fact that we are still in COVID and we're still really trying to understand the circumstances of it. I might toss that to Irene a little bit to talk about like what we're thinking about as we think about this dashboard and whether that's something that you think could be interesting here.
Well, so I think it is something that is important. SWHR, we've been doing some tracking and amplifying some of the research that's been happening with COVID and long COVID over the last couple of years. One of the things when we put together the dashboard, and like Caitlin mentioned, we started in 2018, we looked at a lot of data availability. And so the causes that elevated to the top that we, are focusing on, they can change. So I think as we look, as more data is available, now that we're in middle of 2022, starting to look at what the 2020 data looks like. And then in the years to come, yes, that it'll be something that we'll be able to track. But I know some of the early COVID data was kind of all over the place. A lot of the things that we saw were really pulled only in the first month or two and then extrapolated over the next year. But I think now that there's some dedicated research and focus there, that's something that we'll be able to address and highlight in the coming years.
Great. And Caitlin, to that point, I think there were a lot of challenges that you saw as you were taking on this project in terms of the data itself. I wonder if you could elaborate on some of the things that you discovered as you were digging into this.
Yeah, definitely. So kind of like Irene mentioned, for this dashboard, we started with 2018 data and, as our baseline. And that was on purpose because, as once complete and, complete data is released for like 2020 and on, that data is, for lack of a better word, going to be a mess. And so luckily, like so far, the CDC has released some 2020 mortality data, and we are seeing that they have designated a new code for COVID as a cause of death, and it has been stratified for sex, age, race, and other measures. But for COVID specifically, I mean, there's a lot of data collection efforts from state health departments, but not all departments collect data the same way. And so for Alzheimer's, like kind of what I was highlighting with that table on data availability, it's just really important that data is stratified by sex. So for prevalence data for Alzheimer's, we had sex alone, we had age alone, we had race, ethnicity alone. And while that's great, and that does tell us a lot of stuff, it doesn't fully give us a picture, what are the, ages of women? What are, the races of these women that are getting Alzheimer's and that are living with Alzheimer's right now? And so just, kind of stumbling on, wait, like we don't really have this data. Where is it? And I think just kind of highlighting that. And I think we're doing that. We're trying to do that with the health dashboard to just kind of present what's out there and, kind of work with that and encourage more robust data collection.
Yeah, it also sort of reminds me to, not that I need to be reminded of this, but I often talk about these data issues. And so since we have a captive audience who, if you all are doing this work, one of the things that we discovered both through the dashboard piece, but also through other work related to how to transform the public health data system so that it's really looking at health equity, is that you cannot necessarily collect data of sex and or gender, as well as data on race and or ethnicity and put them together. So you could know one thing, but you wouldn't necessarily easily be able to tell where disparities lie, in terms of what the sex differences are that are also aggregated by race or ethnicity. And so that's a real problem when you're really thinking about how to address disparities. As well as sort of the standardization of data collection, et cetera. So that does present a lot of challenges, I think, generally in tracking some of these issues. I think hopefully if we can start, advocating for standardization or making sure that everyone's collecting similar data so that we can do that, that would go a long way. But it also leads me to ask you, Lindsay, knowing sort of this area and thinking about where there are opportunities, what are you looking at in terms of opportunities on the COVID or long COVID front? I mean, every day there's something new coming out of particularly the federal government and opportunities to engage there as they're building these systems.
Yeah, thanks, Katie. And I do think there are so many different opportunities to engage on this topic specifically. SWHR, in the past few months, responded to an NIH request for information about the intersection of the COVID-19 pandemic on the health of women. And one of the pieces that we responded to there was the role of COVID and long COVID in a women's life course. So how do those things affect things like pregnancy and postpartum and women's mental health? So beyond just the study of the biological drivers of long COVID, there are additional opportunities there that relate to women specifically. And I think we'll continue to advocate for research there. I also think there are some opportunities related to the biomedical research workforce and how women were affected in that way. So looking at policies from institutions like the National Institutes of Health and how they're creating policies in the aftermath of COVID-19 to support women who were having to take step backs or leave work entirely to assume caregiving responsibilities will be something important. And then there's also kind of a systems level focus that I think we could engage in. So looking at public health infrastructure and data surveillance and systems like that. The data piece that you were just referencing, Katie, I think is going to be critically important too. So I think there are a lot of different approaches that we can take to this, making sure that our federal research institutions continue to be supported. You know, we saw also during the COVID-19 pandemic that a lot of research was either stalled or halted entirely. And so making sure that they receive costs to start that research back up again will be key too.
Great. Irene?
And if I can, just do another, I guess, shameless plug, I think a lot of times we look at outcomes to remember as far as the research investment to continue with the basic research and the underlying causes and being able to look at, really how is sex a play and how do hormones play into COVID infections and how it affects the body. And so I think that taking it back also, we know we like the downstream impacts, but also looking at the basic science and the mechanism for what's going on and making sure that there's enough research investment and support and priority there as well.
Yeah, absolutely. And we have a comment here just indicating that we need more research and awareness on long COVID. We completely agree. It's really critical. And it's interesting too, this particular person said that her niece had COVID 2 years ago and still has limited sense of smell. And if you think about it, we're 2 years into this and there's just not a lot that we know, and we're going to have to continue to follow and track that, which will require additional funding to continue to do that. We see this no sense of smell at all. Okay, well, that is also something we need to look into, right? So thank you for that clarification, commenter. Really looking at how do we centralize a lot of these conversations so that we can then advocate for better collection, but funding at the end of the day is something that's going to be really critical, particularly as we're tracking what happens so that we can then continue to lay the groundwork for the future here. One commenter had a question about, and this is something that we will certainly sort of keep in mind as we're engaging, particularly in the Alzheimer's space, is if there's a potential contributing relationship between herpes simplex virus and Alzheimer's, since that primarily affects women and minorities and is widely recognized association with neurological complications. And I think that is all to say that there's a lot that we don't know. And there's a lot in terms of associations that we still need to ask these questions of. So I think that's certainly helpful as we're thinking about that. Let me see if we have anything else coming in. All right. Feel free again to pop any questions in the question and answer or in the chat. I guess I would ask each of you maybe to do a round robin for me in terms of what, and you will not be held to this, but what do you think is sort of the most important thing to take away in terms of women's health and women's health research? And I'm going to put Caitlin on the spot first, and then we'll go to Irene and Lindsay.
Yeah, so I think kind of, my presentation was a whole lot of data, kind of, what is this data telling us, where is this data available? And so I think, just from my presentation, just the importance of sex stratified data. It's really, you think it's really simple, but we're seeing that when you really get down to it and are looking for it, that it's not always there. And so, men and women are different and we need to study them differently. And so just kind of, stressing that and, in all of our efforts, for research, that we need to really kind of separate the two. And, because they really, COVID, all these other things really affect females and males differently. And so, yeah, sex stratified data, that's an important one.
Great. Irene?
I would say coming out of research and when I was even at the bench, you put in grants and you look for something that can get funded. And you may not want to, you don't always pursue the question that you really want to pursue because you might not have the proof of concept or the evidence. And that it's so important that we still are able to think big and we're still able to dream big when it comes to our research, asking hard questions and tackling them. Because at the end of the day, there's still so much that we don't know, and they're difficult questions, but if we don't address them, we won't really have the advancement in women's healthcare that we look for. Collaboration is key, and we know the dollars are tight, but if we don't go for these grand challenges, we're not going to be, we're not going to make grand steps in grand advances. And so I think that that's something that pushes against the ability to innovate. Is just really, I think, and so it's from the reviewers and the funding side, but then also from the researchers, as much as possible to be encouraged to dream big, ask hard questions, tackle them, and then those that are reviewing those proposals to invest in those big questions and set us up for the collaborations that can help us to answer them. And so that's kind of the nugget that I think would be extremely important. I know it's easy to go for the low-hanging fruit or the safe question or this mini question, but I think some of the challenges we have, for example, the long COVID, looking at herpes and Alzheimer's disease, how we present the research, if we don't do the hard stuff, we're not really going to get the answers that we really truly want to be able to advance women's healthcare.
Amen. Lindsay.
And coming at it from my lens, I think I would say that there are so many diseases and conditions and life stages that either differently, disproportionately, or exclusively affect women. And partnerships and really tapping into subject matter expertise are critical. And ultimately, advocacy is more important now than ever. You are the people that members of Congress want to hear from most. Your message is the one that will resonate most. And while we may all be operating in parallel on different women's health issues, at the end of the day, a rising tide lifts all boats, and we need as much research investment as possible in women's health. And any investment at all will set us up for improved outcomes for women and their families across the country.
All right. Well, that leads me to sort of what I like to tie a lot of these programs in with, and have been making sort of a call to action to the community broadly about working together to make sure that we can implement or create a large, broad scale women's health initiative here in the US, but also globally. And all of these pieces are really important, right? You need the data, but you also need the research workforce, and you need to do the hard things, as Irene said. And that ties into the policy, because without the support of the public sector, without the investment there, we're not going to be able to do those hard things, or really make these discoveries that so desperately need to be made. And so I think with that, I want to thank you all. I want to thank the SWHR team for coming together and sharing all of this information and really thinking about how we tackle emerging women's health issues, but also continue to invite you all to engage in the conversation. And of course, want to thank VCU for giving us this platform, but also for the Women's Health Conference. It's so important. I'm so glad that you all are participating, and looking forward to watching the conversation as it continues. So thank you all for joining. Have a great day.